Hello. Today we'll be talking about Karla and the case of the endometrial conquest. Now, this is a figurative title, but it should make sense in a few slides. So, meet Karla. She is a 37-year-old female, although we don't know how she identifies. She is a single sexually active lawyer. Now, I don't have a picture of Karla today, so we'll be using a representative model for the purposes of this presentation. Before we begin, it's important to note that we don't have the full picture of Karla. We don't know her past goals, we don't know her past experiences. She's probably a woman of many titles with many conquests in her life that she aspires to have. So before we go about our care today, it's important not just to see Karla as a name tag or a silhouette. She is a complete person. Her chief complaint in the ER today is progressive right lower abdominal pain and spotty vaginal bleeding. And it's important to note that this right lower abdominal pain not only is it progressive, but it wasn't responding to Advil that she was taking. There was no alleviation. Her past medical history shows dysmenorrhea, a cervical cone biopsy at the age of 24, 2 pregnancies, however, these did not result in 2 live births. A family history shows that she has a father that is live and well, but her mother died at the age of 44 of bladder cancer. Now, there's a lot that we know about Karla, but there's even more that we don't know, including some of these things here. The magnitude of the pain, and being in the ER, I have not dealt with Karla before to have a reference point. Going off of that, I don't know how much Advil that Karla took to alleviate this pain. Or more so, if she takes Advil on a day-to-day basis, that may be adding to the overall amount of Advil that she has in her system. She claims to have spotty vaginal bleeding, but at one point in her menstrual cycle. Is this while she's on her period, showing us a lighter period, or does she have spotty vaginal bleeding independent of when her period is? She had the cone biopsy at the age of 24, but I don't know the results of that. And we know that she got pregnant twice and that she did not have 2 live births, but I don't know the reason behind this. This could be elective, or this could be a miscarriage due to some underlying medical condition, which would be concerning to me as a physician. Getting to know Karla a little bit better, upon physical exam, we see that she is pale and moderately obese. Lab findings indicate that she has mild normocytic anemia, elevated BUN, and creatinine. We know that she has pain in her right lower quadrant of palpation, but there is no rebound tenderness, which is important for us. Some more informational deficits. She's pale, but is her pallor irregular for her? We know that she's anemic and that she has elevated BUN and creatinine levels, but is this part of her normal homeostasis? Or could this reflect a more acute, more concerning issue that's presenting itself to us today? So, to determine what options we were dealing with, I consulted a few resources like Visual DX and a point-of-care tool such as Dynamed Plus. And using these resources, I was able to narrow down my differential to 5 options that approach Karla from a few different angles. Starting at the bottom with antiphospholipid antibody syndrome, I looked at this because of the link between multiple failed pregnancies. Now, whereas this autoimmune disease does approach the elevated BUN and creatinine levels, it doesn't address the recurrent dysmenorrhea, and nor do I know that these failed pregnancies were a miscarriage or elective. For pelvic inflammatory disease, we addressed that, but I chose to reject this option because I didn't know that she had a history of STIs, nor does she present with adnexal, pelvic, or cervical tenderness, which are criteria for this diagnosis. As for appendicitis, I was interested because of the right lower quadrant pain, but this patient, Karla, doesn't present with a mild fever, nor does she have rebound tenderness, and it doesn't address the dysmenorrhea. I looked at ectopic pregnancy as well, but because I don't have a history of irregularly timed periods or missed periods, and because it doesn't address the dysmenorrhea history, I chose not to focus on this diagnosis, at least not as the underlying problem. That being said, I still think it's important to test for pregnancy. And addressing the appendicitis below that, I still think it's important that we can do things within our ER to look at this quickly to understand if this is worth ruling out or not. I ultimately decided on endometriosis as my diagnosis. This diagnosis attributes causation to her dysmenorrhea, and a clinical presentation of endometriosis pain is characteristic to not respond to NSAIDs, or in other words, Advil, for example. So, to start off, we're going to talk about some anatomy. We're going to focus on the uterus today. And as you know, the uterus has 3 distinct layers. The most important and the innermost layer is the endometrium. We know that it's going to grow and shed with each menstrual cycle, and it can serve as implantation for the fertilized egg. To harp on the most important aspect of this disease, the endometrium is in the endometrium is in the uterus. However, in the case of endometriosis, this is when the endometrium leaves the uterus. The etiology is not well understood. What we know is that the endometrium leaves the uterus to gain the adjacent territory on or around the uterus, a conquest of the endometrium, so to speak, leaving the uterus and going to adjacent areas. So shown here on the right is an image of different areas where you might find endometrial tissue or an endometrioma. And common places include the ovary, the pouch of Douglas just posterior to the uterus, and the abdominal wall or the peritoneum. Important areas clinically that aren't shown on this diagram on the right are going to be the cervix and the oviducts. Now the cervix is important because this is the passage that allows for the sloughed endometrial tissue and lining to shed with each menstrual cycle. But if we have a growth of the cervix, this can occlude that, and it won't allow us to shed as much of this endometrial tissue and to get rid of it. This could look at a macro level like a spotty vaginal bleeding. The oviducts could also house endometrial tissue or this endometriosis. And something we know about the oviducts is that this is where the egg, when ovulated, is most likely to get fertilized. And because we know that the egg's ultimate destination is the endometrium, having endometrial tissue in the oviduct could result in a pregnancy that implants in the oviduct, which will ultimately lead to an ectopic pregnancy, which can be problematic. Like we discussed before, pain during menstruation that isn't responsive to NSAIDs is characteristic for endometriosis. And abdominal pelvic tenderness is also characteristic. There are many complications of endometriosis, which include adhesions or cysts, both of which can cause pain and risk rupturing, but also infertility. And whereas it may be easy to debate the fact that Karla isn't infertile because she got pregnant twice, we don't know how long ago she got pregnant, and we don't know how many failed pregnancy attempts there could have been in the process. So it's good to keep this in mind. Confirming a diagnosis, we can use ultrasound. Now, ultrasound is a first-line test. And looking at the ultrasound, as seen in the right-hand images in black and white, we're looking at hypoechoic regions that give away an endometriosis, or darker images. Generally, this is a transvaginal exam, but it can be done transabdominally as well. And if ultrasound does not work, you can also use laparoscopy, which will show the endometrial tissue as a dark powdery type of lesion. And here we're looking at this dark powdery type of lesion as shown on the abdominal wall. Confirming a diagnosis, as well with other emergent tests, is important that we address pregnancy and appendicitis as previously discussed. Now, I may or may not expect a pregnancy test to be positive in this case, whereas a positive pregnancy test isn't indicative or characteristic of endometriosis. Because we may have endometrial tissue in an opportunistic place for an ectopic pregnancy, it's still something that I want to look for and I might actually see a positive result for. As shown in the bottom right image, we're looking at an ultrasound that would indicate to us a positive ultrasound exam for appendicitis. We're looking at the blind-ended pouch of the appendix, and just next to it, labeled with A, is going to be a region, an abscess, that is characteristic of an appendicitis. Other diagnostic markers include a cancer antigen 125, which we can see via serum, anti-endometrial antibodies, and myofascial trigger points, the latter of which is important coming from an osteopathic school. However, due to timeliness and a lack of sensitivity and specificity, these aren't ideal for our work today within the ER relative to other tests that we have. So before we go about treating Karla, it's important to establish or to address some ethical concerns. And the first, and maybe the most important, is establishing a doctor-patient relationship, and that it's important that Karla feels comfortable coming to me to address what she wants for herself, but also feeling comfortable to me to address things that are relevant to her history that I may not have got the first time around. It should not surprise you that I have an incomplete history from Karla. Why is this so? Well, this could potentially be due to the fact that she might feel guilted or embarrassed about parts of her medical history that she may not feel relevant or just doesn't want to share. Perhaps she didn't have miscarriages in her past, and these were elective abortions, and she doesn't want to feel judged for that. Or perhaps Karla does have a history of sexually transmitted infections or diseases. These may be things that are embarrassing for her to share with someone, and if she doesn't think it's relevant, she might not make it a priority to discuss. But it's important that she feels not judged within this physician-patient relationship so we can get the full picture of Karla before treating her. It's also important to address the stigma. Karla might not know what's going on. She might not understand what endometriosis is. Maybe she's guilting herself for potentially having failed pregnancy attempts or not being able to follow through with a live birth. This can weigh on Karla a lot, and it's important that we objectively talk about what's going on medically so we can alleviate this guilt that she may or may not be feeling. It's important to respect Karla's autonomy. What does she want? What are her reproductive goals? Can she have kids? Does she want to have kids? And does that make sense with her future goals, her career goals perhaps? We want to keep Karla informed about the repercussions of surgery, but also the risks of pharmaceuticals as well. And branching off from both of these, maybe some alternative approaches that aren't as characteristic of Western medicine. We want to make sure that we're applying our medical treatment to something that makes sense with Karla's lifestyle. So in treating Karla, one of the first things that we can do is symptom management with oral contraceptives. And this is a continuous administration of oral contraceptives that can be progestin alone or also potentially mixed or combined with a synthetic estrogen. You can also use a gonadotropin-releasing hormone agonist or an intrauterine device that is often progestin-based. Now, this is a hormonal approach to treating her pain and her symptoms. We can go through surgery using a local laparoscopy excision, which will treat one endometrioma specifically, or one locus or area of endometrioma. But we can also use a hysterectomy, which will include removing of the uterus. Now, whereas this is maybe a little bit more radical than a laparoscopy, this is advantageous in the fact that it can prolong the period in between different surgical interventions or potentially even eliminate recurrent surgical interventions. But generally, these surgeries are reserved for patients who are not responsive to other treatments. Now, these are both typically Western approaches, and maybe this doesn't match up with what Karla wants. We can use alternative approaches like Chinese herbal medicine, as is Chinese herb referenced here, that actually has research done on it and has shown comparable efficacy to common Western medicines like danazol, but without using a hormonal approach. So it's important that we're addressing alternative methods to make sure that we're giving Karla a holistic option for treatment. And be it from the disease itself or potentially residual from some of these treatments, Karla may be facing or maybe is currently facing will face infertility. So for that reason, it's very important to me that we are setting Karla up with either her PCP or an OBGYN, and if she doesn't have one, to set one up with a new PCP or OBGYN to make sure that she can not only manage her pain and her symptoms, but also that she can family plan if that's something that she wants. Ultimately, with these things in mind and with Karla's cooperation, I feel confident that Karla will have a bright future that can meet what she wants for her life and what she wants for her career goals. And with that, I'd like to thank everyone on the PTA committee, and these are my references. Thank you for your time.